So first of all, thank you to you and all of the faculty for giving me such a great chance. And today the topic is the stiff heart and constrictive pericarditis. And I am Dr. Sumair Ahmad, FCPS cardiology, and working as a non-invasive cardiologist here at Pakistan and diplomat Echo board and diplomat CT board. So today the objectives are to outline the clinical clues and diagnostic challenges in constrictive pericarditis and to interpret key echocardiographic findings and to discuss a little bit about the other pericardial syndromes like acute pericarditis and other differential diagnoses like restrictive cardiomyopathy, severe RV failure, and briefly about their hemodynamics as well. So briefly discussing about the constrictive pericarditis, it is actually an inflammatory process of pericardium causing the fibrosis, thickening, and scarring of and calcification of the pericardium. And in developing parts of the world, the tuberculosis is most common cause. Here in Pakistan, we see more than 90% of the cases pericardium constrictive pericarditis is due to the tuberculosis, while in West it is much less, but most frequently due to the cardiac surgery, idiopathic, and after a viral infection. But can acute pericarditis, any cause of acute pericarditis can be converted into a constrictive physiology. So there is, and we cannot forget this lady. This is one of the great scientists, Norwegian cardiologist, Dr. Liv Hatley, from 1936 to 2023. So this lady has done a very, very great job in diagnosis of the constrictive pericarditis and their hemodynamics explanation. So we can say this, she is one of the pioneer of the Doppler echo. So if we are coming to the clinical clues, what a patient present to us in the OPD or in the emergency, they mostly present with progressive increasing shortness of the breath, abdominal fatigue, abdominal fullness, and what we examine is there is an ascites, pedal edema, raised JVP, and because of this examination signs, and if we see the ECG, we got most of the time low voltage in sinus tachycardia, and in the legs because of the congestive LFTs, we got the congestive hepatopathy. So this is one of the well-known study done in constrictive pericarditis, Vance et al. In 2014, which actually briefly describes the most important features to understand the constrictive pericarditis. And these are the presence of respiratory-related ventricular septal shift, high medial mitral annular velocity, especially it is greater than 9, and hepatic vein expiratory diastolic reversal ratio greater than 0.79. So this is very much important. When all of these criteria are combined, they show us a sensitivity of 87% and a specificity of 91% in the diagnosis of constrictive pericarditis. So and even one single feature, we cannot diagnose with one single feature because the features can be presented in other diseases as well. So to increase the sensitivity and specificity, we have to combine all of the echocardio features. So if more and more echocardiographic features are present, there are more increase in the specificity and increase in the sensitivity. So we have to combine all of the features to diagnose the constrictive pericarditis. So just briefly summarizing what basically we see in the echo. So these are, and I will actually also discuss each of these points separately to make a great concept of constrictive pericarditis. And this is our actually thick and shiny pericardium, abnormal septal shudder, septal shift, annulus reversus, that is medial to lateral E prime ratio, annulus paradoxus, increase mitral E velocity and EA ratio, and it should be greater than 1.6 in expiration, IVC plethora, and respiratory variation of mitral E wave velocity, and again the hepatic diastolic reversal in ratio. Just to have a great look on this as a real-time echo patient. So this is like one of the our patients, and see, we see here that there is a shiny pericardium, and again there is a septal shudder-like movement along with the pericardial effusion. And this is again a four-chamber view, a apical view, and see here again the typical movement of the septum. And this actually first look of the echo actually help in the diagnosis of the constrictive pericarditis. So again, coming to the second feature, that is the septal shift. See here, this is an actually the spirometry is attached, and this is an inspiration, and again the graph is going downwards. This is an expiration, again the inward, this is an inspiration, then again there is an expiration. So see, what we see here is during the inspiration the septum is coming towards the LV, and during the expiration the septum is again moving away from the LV towards the RV. So this is actually a septal shift, and this is most sensitive feature in diagnosis of the constrictive pericarditis. So coming to the other feature, that is an actually a septal shudder, and we all know that during systole the septum comes into the LV, and during diastole the septum again goes back. But what happened in the constrictive pericarditis, that is that unless the septum instead of going back in diastole, it actually jerk and then again goes back. So this is actually a septal shudder. This is not in case of systole. In systole the septum comes regularly, and then in diastole it does not go back smoothly. In diastole it does not go back smoothly, it actually jerk inside and then again goes back. And this is because of the RV filling and LV filling, and both are competing each other due to the encased pericardium, stiff pericardium. So this is also one of the greatest helping point, that is the respiratory E velocity variation. So again here, this is a four-chamber view, and the pulse Doppler is placed at the mitral valve leaflet, and this is see here, this is an actually a E, and this is an A, and again there is an inspiration, and this is an expiration, this is an inspiration. And what we will do here, we all know that during the inspiration, the LV filling decreases. Therefore, this E velocity decreases, and during expiration, E velocity decreases. So, how we calculate this? We actually minus from this great value and this lowest value, and then actually divide with the greatest value. We got a percentage of mitral valve. So if there is an E velocity decrease by 25%, and during inspiration, so this is one of the criteria that of the diagnosis of constrictive pericarditis. And if we see the vice versa, there is an increase in the tricuspid E velocity greater than 40%. So remember once again, during inspiration, mitral E velocity decrease by 25%, and during inspiration, same, the tricuspid E velocity increase by 40%. So this is one of the criteria to diagnose the constrictive pericarditis. So this is next feature, like annulus reversus, and we all know that normally the lateral E prime is greater than medial E prime. But in case of the constrictive pericarditis, since the pericardium is tethered, so the lateral E prime here it becomes actually equal or less than the medial E prime. So again here we have kept them to the septum Doppler, tissue Doppler, and we see here is the E prime is 12, and here tissue Doppler is placed at the lateral pericardium, and the tissue Doppler is here, E prime is 10. So this is actually a reversed and opposed to the normally patient we see. So when there is a ratio is greater than 0.9, it means 1. So it is an indicative and again a feature of constrictive pericarditis. And in more than 75% of the patients, we have got this feature in surgically proven constrictive pericarditis. Again, annulus paradoxus. What is an annulus paradoxus? We see that in the patients of restrictive cardiomyopathy or other myocardial patients, that whenever the pulmonary capillary wedge pressure is raised and EA show the grade 3 diastolic filling, we normally see the highest filling pressures and the high E to E prime ratio. But in here it is in paradoxus. We see because of the rapid filling in the diastole, E is much superior than A wave, and and we also got in this E prime also greater E prime and greater than 10. So the ratio E to E prime actually become less, and EA ratio become increased. So it is actually paradoxical. So the in patient with constrictive pericarditis, E to E prime is inversely correlated to the wedge pressure and paradoxical to the positive correlation found in patient with the myocardial disease. So this is also one of the interesting features here is actually Doppler is placed in the hepatic vein, and normally we know that the flow comes from the hepatic vein to the IVC, and this is a forward flow. But what happened in the constrictive pericarditis, and there is an expiratory diastolic reversals. So when we again take a ratio, if it is in greater than 0.79, it is an also 88% specific for the diagnosis of constrictive pericarditis. Because in the expiration, the septum is from the LV shifts towards the RV. Therefore, because of this encased pericardium, during the expiration, the all pressure goes back to the RA and then gets back to the IVC and then again to the hepatic vein. So, because this is all because of the exaggerated ventricular interdependence, the septum it actually shifts to the RV during expiration. And this is actually not the case with the restrictive cardiomyopathy, in which there is a separate physiology, in which there is a reversal in inspiration, because the myocardium actually does not properly relax in inspiration, and because of the raised RVEDP in restrictive cardiomyopathy, we got the inspiratory hepatic reversal, but in this case, we got expiratory hepatic diastolic reversals. So I have already described each of these features, and each of these features have a separate sensitivity and specificity for diagnosis of constrictive pericarditis. So I will not does not read whole slide, but we see that if there is a ventricular septal shift, how much there is a 93% sensitivity and 69% specificity. If we come to the second point, mitral E velocity, then third point, medial E prime velocity greater than 9, and then lateral E prime ratio, medial to lateral ratio, and then hepatic vein reversals. So all of these having about 80 to 90% sensitivity and specificity, but when we combine these features, their sensitivity and specificity, of course, rises. So I will also discuss the unique pathophysiology, like dissociation of the intrathoracic and intrapericardial pressures, exaggerated RV and RV interdependence, and equalization of diastolic intracardiac pressures and with the pericardial pressures. So coming to the first point, This is a very much important and interesting concept. See, on the left side, like in concordance, in the normally, what happened when we inspire, uh, there is an increase in the intrathoracic cavity pressure negativity, and there is an actually suction pressure, and this pressure actually transmitted to the pulmonary veins, and then it is again transmitted to the left atrium and to the LV. As a result, there is a filling of the LV. This is I'm talking in the normal patients. But what happens in case of a constrictive pericarditis? There is a dissociation of pressure. It means when we inspire, this actual suction pressure, what I can say, is does not transmitted to inside of the LV because of the encased and stiff pericardium. As a result, the suction pressure does not transmit it. As a result, the filling is decreased during the inspiration. Here is also an hysteric because this is because there is a decreased filling during the inspiration. So this is an actually a concept that there is a mismatch of the intracardiac and intrathoracic pressures. So same here, the exaggerated ventricular interdependence. We all have a normal, little bit ventricular interdependence because this is our normal physiology. But what happened? This is an abnormal. This will become abnormal when this is an exaggerated. Normally, ventricular interdependence is present in our heart, and this is about 5 to 10% variation. But when it exaggerated in a way that it caused a E velocity variation of 25% and 40% on dicuspid, this has become pathological, and the ventricular interdependence may be present in other pathologies like pulmonary hypertension and other things. So this is an equalization of diastolic pressures. This is typical. This is not related to the echo, but we see that this is a dip and plateau sign. So this is also one of the interesting GLS because we see during the strain that the pericardium is actually tethered to the lateral wall, and the septum E prime becomes more and more and greater than 9. So how this is septum GLS become more present towards that is increased greater than -20. So this hot septum like now, because the laterally the E prime decreases and the medially E prime increases. So the reduction in the longitudinal strain in then areas of the LV free wall and relative sparing of the septal longitudinal strain. This is also color and mode. This is also help us in differentiating from the restrictive cardiomyopathy and constrictive pericarditis. This is flow propagation velocity, and this is actually the speed of the blood traveling from the base to the apex. So if it is in greater than 100, because we know in constrictive pericarditis, because of the relaxation, there is a rapid flow from the base to the apex. And see here, if it is greater than 100, it is in diagnosis supporting the constrictive pericarditis. But in case of restrictive cardiomyopathy and other myocardial disorders, this is typically less than 55. So this is an actually speed of the blood from the base to the apex. And then to consider the multimodality emerging, it is of course whenever there is an inconclusive echocardial fractures, atypical clinical presentation, and in settings of the other pathological, if we have a doubt like an ACS and neoplasm and infection. And I have to just show a little bit both the CT and CMR. So look at this, like in CT, the constrictive pericarditis look like that. There is an how it is an thickly, heavily calcified, and in CMR, this also help in the diagnosis of the constriction and other in the acute pericardial therapy whenever this is an inflamed in the T2 gadolinium enhancement because of the uptake. We can inflammatory markers. We can start the therapy for acute pericarditis as well. So just a little bit rest, take a deep breath, and see the beautiful scenery. This is only to refresh our minds. And since the time is short, I can escape this. And a little bit discussion about the differential diagnosis and of restrictive cardiomyopathy and constrictive pericarditis. Just remember one or two things. There's in restrictive cardiomyopathy, we see a E prime is very much less, and in constrictive pericarditis, see the E prime in the length, it is greater than 9. And this is very much important concept, because E to E prime become higher in restrictive cardiomyopathy and lesser in constrictive pericarditis. So we again see here, whenever there is an inspiration and there is a decrease in the LV filling, and of course increase in the RV filling, and whenever there is an expiration, there is an actually a discordance, and there is a decrease in the LV, and here is an increase in the LV filling and decrease in the RV filling. There is an vice versa. But in restrictive cardiomyopathy, during inspiration, both LV and RV increase, and in expiration, again both decrease, and here both increase. So there is actually a discordance, and here is an actually a concordance. So this is also one of the important feature of constrictive pericarditis. So again, in inspiration, there is no change with respiration, and while this is decreased during inspiration, and this actually increase. So severe RV failure, this also actually an functionally restrictive, we can say, but again, we can differentiate it from constrictive pericarditis, because there is a no respiratory variation, and there is an also a diastolic flow on hepatic vein. So this is also briefly about tamponade: early diastolic collapse of RV free wall, late diastolic collapse of RA, dilated IVC, exaggerated ventricular interdependence, and the variation of 30% and 60% instead of 25 and 40%. So this just briefly the two of four diagnostic criteria we will get to diagnose the acute pericarditis, and majority are self-related. And if in doubtful situation, we see the MRI with gadolinium enhancement may be value in the pericardial uptake. So the take home is, when the comprehensive echo is diagnostic of constrictive pericarditis, no further testing is indicated. And whenever there is an equivocal cases when non-invasive evaluation is inconclusive with clinical findings, then the cardiac catheterization should be performed. So these are all my references. Thank you very much. If there is any question, I can thank you.